The thumb duplication has been called radial polydactyly of the thumb, or preaxial polydactyly, to refer to its place in the preaxial side of the wrist or the radial side of the wrist. Some authors prefer to use the term split thumb, as it reflects more the nature of the disease, as it is not true duplication of the thumb. As you can see in these pictures, it has a spectrum where neither of the thumbs is fully developed, and they are hypoplastic or underdeveloped, and their structures, inner structures, even soft tissue and bone, are not truly well developed. So split thumb was suggested as a better reflection of the terminology. It is classified by the IFSSH through the OMT classification into the radial ulnar anteroposterior axis radial polydactyly, with its variants of triphalangeal thumb, ulnar dimelia, or other preaxial deformities. Embryologically, we know that the upper limbs form between the 4th to 8th week of post-ovulation. So it is thought that the zone of polarizing activity through sonic hedgehog protein, GLI3A, GLI3R, and Hox signaling contribute to the formation of the thumb. It is thought that the rupture of the ectoderm and necrosis of the preaxial mesoderm of upper limb is the one responsible for this radial to ulnar anomaly. It happens, it varies, the incidence between 8 to 140 per 100,000 live births, or 230 per 100,000 total births overall. It's usually sporadic. However, some cases have been reported to be running in families, especially of African origins. Triphalangeal thumbs as a special entity is usually autosomal dominant. It is usually unilateral, as you can see in the X-ray. However, if you see a bilateral case, which represent about 20% of the spectrum, you should start thinking about syndromes and start looking for other causes rather than the sporadic thumb duplication. Male to female ratio has been reported in different studies in different ratios. Most of them have some more male predominance, 2.5 to 1, 2 to 1, but this is really not reflecting the true incidence or male-female ratio, because a lot of cases are underreported, which are the minor hypoplastic thumbs that are removed, and the studies report the cases that they operated, and that varies in some institutions with different presentations. Actually, some studies have more female predominance. When a patient presents to the clinic, preoperative assessment through regular history and physical examination is the gold standard. However, we need to focus in our physical examination on thumb motion and functional use. As the joints go more distal, the range of motion is reduced. Usually the CMC joint is the most mobile among them, then followed by the metacarpophalangeal joint, and the usually interphalangeal joint is stiff to some extent. The first web space and thenar musculatures need to be examined, as usually it is narrowed and underdeveloped. The extrinsic muscles of the thumb coming from the forearm, the FPL and EPL, are usually situated in aberrant positions and inserted in a different way than usual, and needs to be addressed during surgery, or they can contribute to unusual movements of the thumb. The shape of the thumb is very important in thumb duplication, as many patients present due to aesthetic problem, not a functional problem to be solved, especially in minor thumb duplication grades. Imaging studies value is questionable. Most of the classifications of the thumb duplication rely on X-ray. However, we know that less than 1 year of age, the bones are underdeveloped, and confusion might happen because of representation in X-ray of epiphyses, which can change the classification from a subtype to a subtype and change the surgical management. However, it is still used to give an idea about the bony components. MRI, ultrasound, vascular studies are rarely needed or used for evaluation. Classification systems are very important in the issue of thumb duplication. We have saw the Oberg-Mansky-Tonking classification that was adopted by the AFSSH. It depends on the etiology, molecular genetics, and developmental biology to classify the diseases. The diseases that are unclassifiable are put into a best fit category. So that means this classification has the advantage of being able to be revised and modified in the future. So this gathers all the knowledge that we know in all fields of medicine to classify the diseases in categories. The more useful, as we can see in this slide, these are cases presented by Dr. Özçelik and Mersa. We have a very large spectrum of thumb duplication, from minor thumb duplications to a more complex degrees and to even zigzag deformities, which we cannot use, which we need to classify in order to communicate between each other as medical practitioners and to plan our surgeries, decide on which part to go and deal with, and to follow up our results and prognosis. So the first attempts were done in 1966 and 1967 by Igawa in Japanese and Milisi in Austria, who represented various thumb polydactyly classification systems in their own native languages. The first English classification system was proposed by Wassel in 1969, who was a resident under Dr. Flat. So nowadays, more authorities prefer using the term flat classification in recognition of Dr. Flat's efforts. According to this classification, he goes from the proximal to distal separation and classifies it into groups. The more common types are type 4, then 2, then type 7 in this classification. Although some authors have objected on the inclusion of triphalangism as an entity in the thumb duplication. The problem with it presents the main frame that everybody reports when they do their researches, and our medical literature relies on a Wassel classification nowadays. However, it has the limitations of that it relies only on X-ray, so it underrepresents the soft tissue conditions, the tendons, the ligaments, the stability of the joints, the movement of the joints, and the function of the thumbs itself, and which one is more developed or underdeveloped, that which cannot be indicated by X-rays. And these are all very important factors in deciding the type of surgery and which thumb to be preserved and which thumb to be sacrificed if it is going to be done. It also doesn't include a lot of variants of thumb duplication. In one paper, it was reported that 40% of their cases couldn't be classified according to Wassel system. So the Rotterdam classification was proposed by Zuidam et al. By combining elements of Wassel, Buck-Gramco, and Apton taxonomies. It is a more complex but more variable. The odd numbers give incomplete separations, and they indicate incomplete separations progressively from distal to proximal. The even numbers indicate complete separations, again from distal to proximal. The subtypes of triplication are represented by T, triphalangism TPH, hypoplasia or floating thumb by H, deviation by D, symphalangism by S. And to finish it, it includes a U or an R to indicate which is the underdeveloped thumb, the ulnar or the radial part. The problem is that it is more complex, it is less well memorized and utilized, and again, it relies on X-ray. In order to simplify things, Chung et al. In 2013 tried to propose a simpler, more useful classification in surgical decision-making. They classified it into 4 types: the joint type, where each component shares its own separate joint articulation; the epiphyseal type, where the epiphysis is common between both of the underdeveloped thumbs and one joint joins them in the metacarpophalangeal or interphalangeal levels; the enchondroma type, where the branching happens at the metaphysis, so it represents kind of an enchondroma; and the 4th type is the hypoplastic type, where the stem of the hypoplastic thumb is only connected by soft tissue component without any bony or ligamentous, bony or cartilaginous components. It has been shown in some studies that the rate of recurrence of surgery is more in types 1 and 2 than types 3 and 4. To adjust for the problem of function and cosmesis, scoring systems have been proposed, starting with the TADA score in 1983 and ending up with the Japanese Society score for Surgery of the Hand, HORI score, in 2009 after 26 years. We can see that the elements in TADA score are include some evaluation of the joint movements, the deviation, and the aesthetic aspect. However, the Japanese Society for Surgery of the Hand is more inclusive of more plans of joint movements, active and passive, in addition to more items to be evaluated in terms of cosmesis to make it more objective, and including the surgical scar, the anticipated surgical scar in the future. It has also been the only one to include subjective score of pain and satisfaction from the patient. That makes it of more value in evaluating, because as we said earlier, a lot of patients present for aesthetic problem, not for a functional problem. The results are rated to excellent, good, fair, and poor. This represents a good way for evaluation of post-operative results and following up the patients on long term.